Well, welcome to This Might Sting, a program that's all about giving you the latest news about health issues with a big focus on evidence. My name's Julie McCrossan, and Dr. Aidan Barron is joining us. And Aidan, an amazing lineup, new ways of receiving ketamine for depression, government backing for it, help for severe peanut allergies, some wildness on TikTok about do-it-yourself sunscreen, and we'll pick that apart, but also the worrying things happening with funding for science in the United States. And so, as always, a lot to talk about. But can we come to this thing of ketamine being on the Pharmaceutical Benefits Scheme and in the form of a nasal spray? So, what is it? What is it for? And is it good news that it's on a nasal spray?
So, I guess the long and the short of it is that for a while now, we've had a thing called treatment resistant depression, which is a constellation of symptoms. If you think of depression, low mood, less enjoyment in daily activities, difficulty motivating oneself to do tasks, and on the severe end of things, suicidality and a feeling that life's not worth living anymore. And it's a really common and really burdensome disease on the individual, on their families, on society. And we need to be doing better to help people. And we've come a long way already. And stigma around depression has dropped a lot. Most depressions, when we talk about depression being biological, it tends to last 9 months, a year and a half, 2 years max. And there's mild, moderate, and severe depression. And for the mild depressions, we tend to treat them with things like cognitive behavioral therapy, psychotherapies. And as they get into the more moderate end of the spectrum, where they're having a big impact on someone's daily life and perhaps putting that person at risk in terms of suicidality, we tend to start using medications like antidepressants, which have huge benefits and also some side effects, as every effective medicine does. We then come to the area of treatment-resistant depression, and it's a contentious topic. Some researchers will say that there isn't even such a thing as treatment-resistant depression. Other clinicians will say there clearly is. I have a lot of patience with it. What essentially we're talking about is a depression which is bad. It's having a big impact on someone, and the conventional treatments that we're trying aren't working. So the first antidepressant isn't working. Then the second antidepressant isn't working. When you're really in the thick of a depression, it doesn't matter how good the psychological therapy is, you need floaties in the form of antidepressants to help you stay above water in order to receive the psychotherapy. And so I often think of antidepressants as being floaties. You can't focus on your swimming technique if you're drowning. You need to be able to float, and then someone can teach you how to swim. With treatment-resistant depression, the floaties aren't working, essentially is the issue. Ketamine for a while has been proposed as a potential solution. And the reason for this, if we go back, is that what we found probably in the late 90s and early 2000s is that when we used a high dose of ketamine to sedate someone, there was a sort of signal towards an anti-suicidal property that lasted about 3 days to 2 weeks. Particularly, and this was in the case of paramedics and emergency doctors, sedating someone who was severely distressed, we tended to find that suicidal ideation or that suicide tendency drive went away for a little bit. Ketamine's an interesting drug. I'm going to nerd out here for a second. We've got different receptors in our brain, and receptors are like locks, and different chemicals are like keys that unlock locks, and then things happen. Ketamine blocks the NMDA receptor. And the NMDA receptor is a phenomenally interesting receptor in the brain. It's involved in all sorts of things to do with mood, neuroplasticity, and excitation of cells. And glutamate, or glutamic acid, the most common neurotransmitter in the brain, stimulates the NMDA receptor. Ketamine blocks it. And so ketamine in clinical use has this really interesting effect where, depending on how much you use, depends on what kind of an effect you get. And we use it all the time in emergency healthcare as paramedics, as doctors, because it's an amazing anesthetic drug. It's an amazing sedative. It's an amazing pain reliever in emergencies. At very low doses, ketamine works in combination with other medications as a fantastic pain reliever. And then as you start to up the dose, what happens is you get the separation from the mind and the body. It's a dissociative. Your mind literally separates from your body. And so even though things are happening to your body, you're not feeling and experiencing the pain and distress associated with that. It's an extreme version of happy gas, which is also a dissociative. And then as that keeps going and going and going, you end up in the K hole, which is a zone where you are essentially hallucinating, because you have such a separation between your mind and your body that you're not really sensing reality properly. And people report things like purple dinosaurs, feeling like they're levitating off the bed, a fear of that they're dying, all sorts of weird and wonderful things. If you are a goer to festivals or a party goer, you'll often see people in the K-hole. They've taken too much. And then eventually you end up with the anesthetic dose, where someone is completely unconscious. But the beautiful thing about ketamine, and the reason we've used it in war surgery and in emergency situations, is it's one of the few anesthetics that actually makes your blood pressure go up instead of down. And it makes your breathing and respiratory rate stay constant rather than dropping off completely.
Just before we come back to its use for resistant depression, you've mentioned just quickly that people might use it at concerts and so on, like as
Mm.
a recreational drug. Is that advised, or is it not advised?
Yeah, look, I wouldn't be a very good doctor if I said that I advise people to go do drugs, would I? But no, the truth is, it's
It could be
no,
dangerous.
and I'm teasing you here. There's a few risks, and the biggest risk is that it's not actually ketamine. And that's the biggest risk. You don't know what you're taking, particularly nowadays. There's a new trend that a lot of the illicit drugs on the market in Australia have nitazines in them, which are a powerful and lethal, potentially synthetic opiate that doesn't show positive on any of the common tests. You really need like high level lab tests to detect it. And I've treated some of the patients with nitazene poisoning, and it's very difficult to take care of them. They go long periods without breathing, and they do die without care sometimes. So the big risk with all illicit drugs is it's not actually the drug you think it is. That's the big risk. The secondary risks are getting the dosing right. You don't know what the concentration is. You don't know how much you're taking. You are making yourself very vulnerable if you're taking too much. And then over a long period of time, there are significant impacts on, if you're taking ketamine on a regular basis, you're going to have an impact on your mood, your ability to function. You're going to expose yourself to a higher risk of adverse mental health effects if you're not very careful with dosing, doing it under supervision. And then you can also develop incontinence and bladder issues. There's ket bladder, which is commonly referred to when people abuse ketamine over a long period of time in high doses. They can develop a spasm and dysfunction of the sphincter in the bladder.
Look, again, when you were outlining how the varied way in which ketamine is used, you were telling us, I guess, the different impacts it has depending on the dose. So obviously the dose and the capacity of the paramedic or the doctor to give the right dose is important. Again, just before we come back to its role in depression and helping people with depression, it's commonly said that they use it to tranquilize horses, which I have to say, as a 5'2" woman who's pretty small, if a little overweight, that's always frightened me tremendously. What's the link with the horse business?
Yeah, look, I'm not a vet, but I'm informed by my veterinary colleagues that they have traditionally used ketamine as an anesthetic for horses, and that it was really common in the equine veterinary practice, and that it came back into sort of human medical practice. I have no idea why they like it for horses, but it's got this sort of pervasive stereotype attached with it that ketamine's for horses. And then we joked in the early 2000s, hey, it's not just for horses, it's great for people too. And it's had a real resurgence in anesthetics and emergency medicine practice because it's such a wonderful drug in terms of the different ways that we can use it for pain relief, for anesthesia, and how predictably it works. And we dose it as a milligram per kilogram of body weight. So we dose it really specifically. Different people get different doses.
So let's return now to treatment resistant depression and the fact that the Pharmaceutical Benefits Scheme is now offering it to patients with this condition. So in a nasal spray format. So can you go specifically to that and what that's about and your thoughts on what we need to know?
So ketamine is one of the many drugs that can be absorbed via the mucous membranes. So like the lips, the inside of the lips, the gums, and the mucosa inside the nose. The rectum is also a mucosal surface. And so a drug like ketamine can be given via nasal spray. And what that does is it makes it much easier for it to be administered in a wider variety of clinical settings rather than needing a drip to be put into someone's arm and given that way. And it makes it a bit safer in that there's a bit more of a sort of delayed onset. It's harder, but it's still very possible, but it's harder to give someone a dangerous dose if you're giving it in a controlled way via nasal spray according to the instructions. And so Spravato is the nasal spray that has been approved. It's controversial. And in psychiatry, this is still very controversial. It's not settled science. And the reason is ketamine works for depression, but so do most antidepressants. What we're talking about is treatment-resistant depression, where the other antidepressants don't work. And truth be told, I've had a good look at the literature, and most of the systematic reviews and meta-analyses, which pull together all of the studies done, would tend to suggest that actually, if it's treatment-resistant depression, even the ketamine, or in this case, S-ketamine, which has been approved, which is the specific form and shape that the ketamine chemical comes in, probably doesn't have that big an impact either, which is a bit upsetting for some people. And certainly the purists would be very upset with me saying that. But it's only showing a mild, at best, improvement when used in conjunction with other antidepressants. This is not the silver bullet that people have painted it out to be.
And I guess it's time we move to our next topic, but I guess if you are unfortunate enough to have treatment resistant depression, your clinicians are probably seeking to help you. And even a mild bit of assistance, if you're faced with something as challenging as that, would be good. But look, thank you. We'll keep our eye on esketamine nasal spray, and no doubt there'll be ongoing research now it's on the PBS. But look, let's turn to peanut allergies. And again, we're looking at severe peanut allergies and some trials in the United Kingdom looking at oral immunotherapy that might be able to assist people with, or at least to reduce the risk of severe peanut allergy. This immunotherapy, isn't it? It's turning up everywhere. So tell us about this one.
This is a really cool trial. And I really want to give my kudos to the team in the UK because they've done a brilliant double-blind crossover trial, which basically means that they took two groups and they blinded the patients in those groups to what they were getting, whether they were getting the oral immunotherapy, the OIT, or the placebo, the sham. Essentially, what they've done is they've said, hey, these are all people, in order to participate in the trial, you had to be really sensitive to peanuts. I'm talking like really anaphylactic to peanuts. If we pricked your skin with a tiny dose of peanut protein, you got a significant welt. So it's this group of people that were enrolled in the trial, people who have proven severe allergies to peanuts. And essentially what they've done with this oral immunotherapy is they have used exposure therapy using the body's own innate immune system. And what they've really done is they've taken microscopic doses of the peanut protein and slowly exposed people to the peanut protein. And again, this isn't peanuts. This is taking peanuts, crushing them up, turning them into a super fine material and extracting just the protein. And when I talk about the protein, I'm not talking about like the weight building protein. I'm talking about the chemicals which signal your immune system that this is what it is. So none of the oils and fats, just the peanut protein. And they've started off with supremely small doses and then worked their way up over a series of weeks. And over this series of weeks, they've worked their way up to pretty high doses to the point where they got people taking 1.4 grams of peanut protein, which is huge. Like that's like a whole peanut. And then what they did is after people succeeded at that, they got them eating actual peanuts and peanut flavored treats and snacks. It worked in 80% of the patients. Now, they only had 21 patients in this study. So it was a small study. This is a proof of concept. They were very selective with who came in. 4 of the patients had multiple episodes of anaphylaxis during the trial. So this was a well-supervised trial. They were in a medical setting to start with. They came into a clinic. They were given a sort of gel film thing to put in their mouth with tiny doses of peanuts, protein, and then escalated, took it home, and over 2 weeks started taking higher and higher doses. And a few people dropped out. But I think this is awesome. This is a huge breakthrough in people's ability to, enjoy so much of what we take for granted. And the reason is they chose peanuts because peanut allergy tends to be preserved as you get older. There are a lot of allergies that sort of die off and don't give you issues as your body gets older, but peanut allergies and severe peanut allergies tend to really stick around. So they said, let's really tackle this one.
You've emphasised that this was done under medical supervision to ensure great safety. And also, it's a very small number of people, and some even dropped out. So I guess I'm a little bit surprised that you're so excited. Can you explain what a proof of concept study is? Is that the key to understanding why this matters?
Yeah, I mean, the real proper term is a pilot study. And a pilot study is essentially you test something to see that, not to prove it works, but to see that it can be done safely and that it's probably going to be able to reproduce results in a bigger trial. A pilot study is you take a small group of people and you run them through the experiment as you would in a bigger experiment and see, does anything terrible happen? And can the experiment actually work the way we designed it to? So if we tried to do a pilot study of testing people's allergic response to, let's say, jelly, and we gave them take-home jelly, and half the participants reported that actually when they took the take-home jelly home, it didn't refrigerate properly, it turned into syrup, and no one wanted to drink it, we would say, great, good thing we only did this in 20 patients. We realized that we need to change the way we do it. Good thing it's just a pilot. We'll change the way we present the jelly. We'll send people home with fridges. All sorts of like logistical process issues get worked out in a pilot study so that when you go to a bigger study, a big randomized controlled trial of 100, 200, 300, 1,000 patients, you've already worked out all the kinks and little issues. And so this is a fantastic trial that I think holds a lot of hope for people, because we don't expect these little trials to show benefit. Usually we expect that in these trials, there's a sort of signal of benefit, but really it's much of a muchness. To have had 80% of people in such a small group experience benefit is wild. Normally we expect in 20 people, maybe 1 or 2 will have benefit, and that's good enough for us to say, hey, this is potentially a winner. 1 in 20, that's a lot of people when you do that to 1,000 people.
And how long do you think it'll be before it goes to a larger study? They do it with big numbers.
This is already being reproduced and patients are already being recruited for larger studies. And the beautiful thing about the scientific community is when someone in the UK finds it works, someone in Australia will go, hang on a second, we should try that here. Because the interesting thing about this study is that there was a predominantly Caucasian population recruited. So they're very careful to note that they didn't have many people from sort of black ethnicities or sort of racial profiles. They had very few people from Asian ethnicities recruited. And we know that there is genetic variability across the world. And so this has to be reproduced. It's not good enough that one trial showed benefit. We need to do multiple big trials that all work out the same way. We need to have different people involved. But it's exciting because, wow, if 16 to 17 out of 21 people experienced benefit and were able to eat peanuts for the first time in their life, I mean, this is awesome.
Yes, and even if it doesn't ultimately lead to a lot of people eating more peanuts, it will bring so much relief to all those families who spend their life, if they're out eating publicly in a restaurant, trying to absolutely be sure that their child or their relative is safe. Look, while we're talking about research, let's just go big picture. We'll hear more about the UK peanut study as it gets bigger. But let's go to the United States, because there's just been so much international concern about what's happening with the Trump administration and universities in general, but scientific research in particular. I think the latest announcement, or one of the latest announcements, is that the National Institute of Health is being told it's going to have a 40% budget cut, which has the potential, I think, to make a massive difference to public health. And I think a serious concern that other countries like France, Canada, and elsewhere are actually trying to poach people out of the United States, because particularly people from other nations are thinking, is it safe to stay here, and will we get the proper collaboration? So your thoughts on what's unfolding in the States and what it ultimately means for patients, Aidan?
The Trump administration's Department of Government Efficiency has irreversibly slaughtered the capacity of American health research. They have set things back 30, 50 years. There are experiments which cannot just be turned off and turned back on again. The research pipeline is not measured in months, it's measured in decades. So in order to get research off the ground, it's years of grant funding, preliminary research, to the point where these massive international collaboratives of multiple universities around the world, multiple research sites around the world, doing incredible science, are able to get to the point where they've got a rhythm, they've got a momentum behind them. And if you lose that momentum, you can't just switch it back on. It takes years to build it up again. And the fact is, it takes decades of preparing junior researchers to become mid-level researchers, to become research leaders. And when you destroy the hopes and dreams of an entire generation of a country's researchers, they go elsewhere. And so we see the active recruitment of senior research leaders from across the US already moving to other countries, moving to Canada in particular. It feels criminal what's happened here, not just because of the impacts on people. I don't want to even go into the ethical implications of turning off funding for things like USAID programs and PEPFAR, the President's Emergency Preparedness Relief against HIV and AIDS in huge amounts of the world. We'll put that aside. The National Institute of Health has been responsible for a huge amount of the medical breakthroughs that we enjoy today. Patients with cystic fibrosis who now live to ripe old ages, who used to die at the age of 5. Treatments for cancers that you and I feel good going to bed at night knowing that actually we have treatments for things like breast cancer and testicular cancer and hundreds of different cancers. The amount of human development which has come out of the National Institute of Health, it is one of the biggest health research doers in the world. And to have slashed their funding without considering how and what they're doing it's insanity. And we're all going to suffer because of it. It's not just Americans who are going to suffer, because it wasn't just Americans who are benefiting.
Absolutely. And also, it's my understanding that in places like Australia, there will be many research groups who are part of a worldwide network of particular studies that might be linked to the National Institute of Health in the United States, so that it's not,
Absolutely.
there's going to be a disruption to the work of people and indeed probably to the jobs of people
We
in
know,
places like
yeah,
Australia as well.
we know that tens of millions of dollars of research funding exists in collaborative efforts between Australian institutes and American institutions. And that's just lost to the ether now. It's really upsetting. Really upsetting. The thing which I think people forget is how much money comes into the American economy through research and development. This wasn't just ethically bad, it was financially stupid. The billions of dollars generated in revenue every year in pharmaceutical products, in technology, devices that we use every day that have come out of National Institute of Health funding. My perfect example of this is people always ask, why should we fund the space program when we've got problems here on Earth? And then they go and heat something up in the microwave. And the only reason we have a microwave is because the Americans had a space program and NASA developed the microwave, which we use every single day. That's a perfect example. When we're doing research, the fruits of that labor are useful on an everyday basis and influence the way we live. It's not just a rare disease fandangle cancer research. The implications of that research are felt every day in the tech we use, in the medicines we use, in the regulations that keep us safe.
I know this is now going into the area of conjecture because we seem to be at a time of such significant international instability. It's very hard to predict the future. But say in the economic area where tariffs are being so damaging to the flow of free trade, nations like Australia and many other nations are looking to diversify their exports and imports in order to not be as vulnerable to what's happening in the United States. And I'm just wondering, are we likely to see similar efforts by, for example, major pharmaceutical companies and other cancer researchers, the really big areas of research where they seek to base themselves in European nations or Canada, you've already mentioned? Will there be a similar attempt to diversify? Whereas once, in my experience, many leading researchers, clinicians here in Australia do spend a period of time in the United Kingdom and the United States, that somehow that's part of your elite career, if you know what I mean. And I'm wondering, will it be good news for Britain or good news for Canada or good news for parts of Europe that people will diversify?
Look, Julie, it's a great question, and I certainly hope so, but I truly have no idea. There's so many complexities in this situation. Whilst funding has been slashed, there's also regulations which have been slashed. And so it's very attractive for private commercial interests to go to places where there aren't as many protections and regulations because you can do more research that's maybe less ethical. For years, we've known that there are multiple less ethically conducted companies and research and development groups who've gone to areas like the Middle East, North Africa, and the global south, i.e. the poorer countries on earth, to do things that they can't get away with in the sort of global north. the wealthy Western nations. So I guess time will tell.
Look, that one's a bit shaky, but we'll bat on with optimism. Let's go to TikTok, because our gig here is to challenge foolish nonsense and to bring evidence-based thought to healthcare. And even though there's a craze on TikTok where they're encouraging people to make their own homemade sunscreen. Now, we're in the land of melanoma, Australia, the freakiest of skin cancers. So what's going on TikTok, and why does it really matter that you use credible evidence-based products to protect yourself from the sun?
Want natural sun protection without chemicals? Let's make a DIY sunscreen using ingredients in your kitchen. Grab a glass container, add coconut oil, raw shea butter, mix together. Move over to the stovetop in a double boiler. Stir constantly to make sure that it melts completely till smooth. Add zinc oxide. Add carrot seed oil. Turn the heat off, mix completely. Add lavender and sweet orange essential oil for fragrance. Stir, let cool, bottle. Voila, your sunscreen is ready. Let's try it out. Apply. This is about SPF 40 to 60, depending on the amount of zinc oxide you add. 1 tablespoon of zinc oxide is equivalent to 15 to 30 SPF.
Now,
Yeah.
Aidan, you're looking a little bit overwhelmed there.
I'm looking dejected. I'm sighing. Look, it's a free country, but my God, like, sunscreen is amazing. There's the way sun cream or sunscreen works, depending on how, I still don't know what's the right way to pronounce it. I should probably look it up. There's two ways that sun cream works. One is that the chemicals in the sun cream reflect back the UV rays from the sun and don't allow them to penetrate to the skin. And the other one is that the chemicals in the sun cream actually absorb the UV rays. So that the same way that if you put a pebble under a heat lamp, the pebble gets hot, the chemicals actually absorb the UV rays from the sun and don't let them penetrate to your skin. Now, there's those two different products. Full credit to the TikToker. She at least used one of the right products, which is zinc. Zinc is one of those reflector products where it actually doesn't allow the sun's UV rays to penetrate through. But think about the products that you've used with zinc in them. It's that thick zinc paste. Because if you're going to use zinc, you actually have to create a full barrier of zinc so that the sun doesn't get through, which is why we tend not to use as much zinc and we tend to use the other softer, creamier, oilier products because they have the absorbing chemicals in them. And those chemicals are things, and they're going to sound scary, and I apologize if I'm butchering the names. There's avobenzone, there's ethylhexyl triazone, homosalate, octinoxate, octocrylene, oxybenzone. They sound like really scary chemicals, but they're not. And I guess the first thing to say is that everything is a chemical. And if I told you what the chemical names for everyday things that we eat are, you'd be terrified. I could give you a list of 23 really long chemicals right now that are all the chemicals inside apple. And in the wrong dose, apple seeds are lethal. There are chemicals inside apple seeds which will kill you if concentrated them and ate 2,000 of them at the same time. Obviously, using conjecture here, it'd take more than that. You'd have to do some chemical things to them. This is not bad advice for someone to listen to and figure out how to poison themselves with apple seeds. It won't work. You'll just feel very sick. But what I'm trying to say here is that people think chemistry names equals toxic. And that's what's coming through in this TikTok. There are chemicals which I don't understand, therefore they're toxic, therefore they're bad for me. And it couldn't be further from the truth for two reasons. One, these chemicals are amazing at protecting you from getting skin cancer and dying. Two, there's a famous saying, the dose makes the poison. And it's by Paracelsus, the father of modern toxicology. And the same thing comes back to that discussion we were having about ketamine. The dose makes the poison. If you drank all of these chemicals in their pure form, you'd get very sick. But you're not drinking them, and they're not in their pure form, and they've been rigorously tested by our Therapeutic Goods Administration to make sure that the current quantity and level and dilution that they're in is perfectly safe. And these chemicals have saved thousands of lives in Australia and will continue to save thousands of lives, notwithstanding the hundreds of thousands of cancers they've prevented.
And can I just say, as I listen to you, because I hear those names and I don't associate them with toxins. When Cancer Council New South Wales or South Australia or Queensland, there's cancer councils all around the country that sell us tubes of sunscreen, and it lists on them what's there. I trust that they are a reputable body that are seeking to stop me from getting melanoma. And not just that, I'm your average 70-year-old Australian. I've had 5 basal cell carcinomas. Is that the right term?
Yeah. BCCs. Basal cell carcinomas. Spot on.
So I've had 5 of them taken off my face and 2 off my arms. And I have the scars to show it. I've got makeup on today. I cover it up. But many Australians, we age ourselves dramatically. We have lots of things cut off ourselves. And for some poor people who get the melanoma and it isn't able to be caught in time and treated well, they die. So, I guess I'll simply say, there is still, I believe, a significant proportion of the population who have trust for the protections of agencies like the Therapeutic Goods Administration, but also for bodies like cancer councils that are working to give us the sunscreen. Just thought I'd throw the trust message in because we need to rebuild that trust, and social media is undermining it. Do you think for the less informed, to be honest?
Totally. I couldn't agree more, Julie. And I think the issue is the do your own research crowd. Because I can't do my own research, and neither can you, because I'm not an expert scientist in sun cream. I'm not an organic and inorganic chemist who's an expert in UV radiation blocking chemicals. I'm a doctor who's able to read scientific research, but even then, if I'm not an expert in that field, I have to trust that the multiple bodies out there who are doing research, who are competing against each other, because keep in mind, science is competitive. It's a competitive sport. Okay, people are probably going to laugh at me for that one. It's competitive. There's an element of rivalry in it in a really nice way, in that people are trying to prove other people wrong, and that's what keeps science honest. If someone comes out there and says, I can do these amazing things with drug X, the first thing the other doctors and clinical academics and scientists are going to say is, I'm going to prove you wrong. And we're going to repeat that trial and see, does it actually work out? Because oftentimes the effect size, the level of benefit isn't as good as it's first touted to be in the first study. So there is an incentive for scientists to prove each other wrong and to compete to see, do things actually work and are they actually safe? So even if you don't trust the government, and I can understand that in this age, not trusting the government is a fear that I can at least accept that people have, and I can understand why they might have it. I think we're really privileged in Australia that our government, our public agencies rather, who are overseen by the government, have a huge amount of rigor and safety in them. And I feel very fortunate to live in this country where we can still trust these public agencies. But I get if that's an issue for you. You don't have to trust them. What you can trust is the thousands of scientists who are competing with each other, who are incentivized to prove each other wrong and still keep finding these things are safe and they work well, and who are actively competing to see, can I create a better chemical, a better one, a safer one that works even better against skin cancer? Not just SPF 30, SPF 50. If you can't trust in public agencies, at least trust in the competitiveness of scientists. There's a great story from the US a colleague of mine shared on Twitter the other day. She said, I couldn't convince my dad that global warming was real until he saw that every insurance company had now increased their premiums to account for the effects of natural disasters because of global warming. And it was at that point that he agreed that global warming had to be real because there would be no economic benefit to the insurance companies, including that if it in their risk assessment if it wasn't. So there was an economic incentive. Now he agrees that global warming's real. And so trust in the competitiveness of scientists.
Absolutely, and of course, the essence of scientific research is that it's reproducible. And that is tested all the time. Look, our time is up. I have to quickly say, when you say you don't do your own research, when I did have stage 4 cancer, I did ask to read some things to help me understand what was happening. But I asked my cancer expert clinical team to recommend 2 or 3 things to read that would brief me, but I was able to rely on it being evidence based. But look, as always, Dr. Aidan Barron, I've really enjoyed our conversation. And what am I taking away from today? You have a think what you're taking away, but I guess I've learned about a proof of concept trial, or the sort of work that's done before big trials are done. And I find that I take comfort in scientific research, and I look forward to changes in the United States so it becomes the home and catalyst for quality international research again. Over to you to take us out, Aidan.
I'm so glad you mentioned that to finish up with doing your own research. Everyone should go out there and do their own reading. You should go out and do your own reading and find verifiable, trustworthy sources and ask multiple people and make up your own informed opinions. But understand that as non-experts, we have to rely on the opinions of experts. So look for trustworthy experts who have spent years and years dedicated to actual scientific research, not somebody on TikTok who wants to tell you that your sun cream has poisons and here's a great way to mix some lavender and essential oils to protect yourself from the sun. That's all from me.
And goodbye from This Might Sting. And remember, take your medication as prescribed.
This Might Sting is hosted by Aidan Barron and Julie McCrossan. Executive produced by Joshua Kirsch. While we always work to give you the best information and tips, nothing in This Might Sting should be construed as personal healthcare advice. You should always make health decisions in consultation with your general practitioner and specialists. If you'd like to hear us talk about a topic on the show, or if you think we've made a mistake and want to request a correction, please contact us at questions@thismightsting.com.au.